I have 10 OSCEs for you. We'll start with the first one. So this is a 38-weeker, 3 kg boy, baby born to second-degree consanguineous parents. Was a well baby at birth, and this sort of gangrene started developing from day 3 spontaneously. Baby was mother's side breastfeeding and progressed, and this is how the baby was when we received him by day 6 to day 7 of life. So the first question is, what is your likely diagnosis? In this well baby, what would be the likely etiology? What is the confirmatory panel of tests for this condition, and what is the treatment? Any takers? I think there are a lot of things on the chat. Yeah. So I think many people have answered purpura fulminans and ecthyma. So this is actually purpura fulminans. And the likely etiology is probably genetic, and most common conditions are protein C, protein S, factor V Leiden, and antithrombin 3. Although now much more genetic conditions for thrombosis are coming up. And the panel of confirmatory tests would include protein C, protein S, antithrombin 3 levels, and also genetic testing. And what is the treatment? So which concentrate you should give to replace protein C? Which blood product? So the blood product is FFP, fresh frozen plasma, which is rich in protein C. So this is the answer: purpura fulminans, protein C, protein S deficiency, or antithrombin 3. And these are the levels. And FFP 2 to 3 times a day, because half-life of protein C and protein S would be around 6 to 8 hours. And heparin and protein C, if activated protein C concentrate is available, that is also an option, but that is not available in India. Okay. So moving on to the second question. So identify the pattern shown in this ECG with justification. What are the drugs to treat this condition, and what is an underlying condition that can cause this ECG pattern, and a drug used for prophylaxis to prevent this condition from happening? Any takers? What is the pattern in the ECG? Yeah. So somebody already answered. It is supraventricular tachycardia. Why do you say it is supraventricular tachycardia and not ventricular tachycardia? So you can see that there is a narrow complex QRS and absence of P wave with a heart rate of more than 200. These are the 3 criteria for justifying that this is SVT, like a basic criteria. The drugs used for treatment of this condition would be acutely, you can give adenosine, or you would do a synchronized cardioversion. And an underlying condition that can lead to this ECG pattern is WPW syndrome, where there will be, once you do a cardioversion, it is important to take an ECG and see what is the pattern. If there is a slurring of the upslope and a prolonged PR interval, then there is that means there is an accessory pathway which is causing this condition. And drugs for prophylaxis would be digoxin or propranolol. So the other drugs other than adenosine would include amiodarone, sotalol, and there are a list of drugs. So at least basic drugs we should know. Adenosine we should know. Okay. So this is a baby who was born at term, who presented with on day 20 of life with increasing head size, poor feeding, and lethargy. And this baby had an ocular finding, which is characteristics of the disease. So what is the CT finding? What is the likely diagnosis? And what is the duration of treatment? So at the CT, we are looking at these things. So any takers on the chat? Ventricle is dilated. Yeah. So somebody correctly called it ventricular dilatation and not hydrocephalus. CMV. Okay. So this is actually calcifications which are also seen in the parenchyma, not just periventricular. So intracerebral calcifications, which is clearly suggestive of toxoplasmosis, and also sporocyst is seen. And this is congenital toxoplasmosis. There's also ring enhancing lesion. The treatment for in pregnancy is spiramycin, and for the neonate, we would give pyrimethamine plus sulfadiazine plus folinic acid for a year. And if there is a high CSF protein or there's active chorioretinitis, we would need to give steroids till this becomes normalized. So I think I left out the one question, the drug in pregnancy. Sorry. Okay. The next thing is what is this chart to identify this chart? Where is this used in? Why it should be done? And what are the 4 levels of evidence according to grade classification? Any takers? So if I'm going too fast, I think somebody please let me know. Anybody? Anybody's read meta-analysis? No? Okay. So this is what is called as a risk of bias charting. Okay. And this is used in meta-analysis to see how is the quality of studies. So see, finally, if a study reports that one intervention is superior to the other, you cannot just blindly believe that study unless you look at whether the study is done properly or not. So these are some of the points which a risk of bias looks at. Random sequence generation, allocation concealment, blinding of participants, blinding of outcome assessors, incomplete data, and selective data report. And why it should be done? It is to assess the validity of the study. And what are the levels of evidence will include very low, low, moderate, and high certainty. So generally, most of the trials which we are getting would be like very low or low. Very few things like would be very moderate and high certainty of evidence. So one thing which is high certainty of evidence, of course, is breastfeeding. Second, would moderate certainty of evidence is immediate kangaroo mother care. So on and so forth. Okay. Identify this object. What is expand ANTT and what are the 4 actions of ANTT approach? What is scrub the hub? Describe the duration and choices of disinfectant. Any takers? Do you all use this in your unit? Yeah, somebody has expanded aseptic non-touch technique. Key part, okay. Okay, so the answer, this object that arrow is pointing is called as a needleless port, a Q site or a Q site. This should be connected to every hub, every IV line, every central line, so that whenever we are accessing, this is also called as a key part, but whenever the answer we are looking for is a needleless connector or a Q site. Whenever we are accessing the port, we should do scrub the hub actions. So what is ANTT and 4 actions and what is scrub the hub? So ANTT includes usage of hand hygiene, using a glove, aseptic technique, non-touch, and key part, key site protection and disinfection. So any of these 3, if you could write, you would get marks for that. And what is scrub the hub? Scrub the hub means you should scrub the hub for 15 seconds and air dry for 30 seconds before access of the port. So these 2 numbers are important. Scrubbing for 15 seconds, air drying for 30 seconds before access of the port. What disinfectant you would use? This is absolute alcohol or chlorhexidine. So these questions would not only be asked, this usually infection control is not only asked in the OSCE, it is many examiners also assess this as a vital component of your Viva or your practical exam, whether you are following infection control practices. Okay. So provide a complete diagnosis of this image and name any 2 syndromes associated and the management. I think this is a fairly simple question, but here the only trick is the complete diagnosis. Any takers? Okay. Which side is a palsy? And why are you saying it's LMN? Okay, right. The left side is a palsy. And so Dr. Anupam has told it is LMN facial palsy. Two syndromes, okay, and management. Yeah. So Ramsay Hunt is usually in older children or older patients post chicken pox. But for congenital types that is presenting in the newborn, it would be Mobius Poland or golden heart. Left lower motor neuron facial palsy is a complete answer. And some of the interventions would include eye protection because this eye would be almost always open. They are prone to keratitis. Physiotherapy, follow-up, treatment of underlying disease, and finally surgical management if it is not responding to physiotherapy. So why it is left? So generally in an upper motor neuron, the upper half is spared. Whereas in the lower motor neuron, the upper half is also involved, which means that the baby does not have furrowing of the brows. The baby also keeps the eye completely open, and lid closure is also affected. So this is why this is a lower motor neuron. So the upper half and lower half are affected in lower motor neuron. In upper motor neuron, the upper half is spared. Okay. So identify the structures A, B, and C. I think this most people are going to answer anyway. And what is this mode? And why do we use this mode? Where do we use this mode? Okay. So, okay, A stands for iota, B stands for LA, and C stands for LV. Okay. This is an M mode, and usually this is used as for LA is to iota ratio, which for the PDA, which is more than 1:1.5, which is significant. So this is the iota. So this is the aortic valve. This is the LV, and that drains into the aorta, and this is the left atrium. So the left atrium drains into the left ventricle, and that drains into the aorta. So this is a parasternal long axis view. Okay. So, eighth question, what are the findings on this infantogram? At least two differential diagnoses, and what would be the outline of medical management in this diagnosis? So, when you're looking at X-ray, you should also look at bones and soft tissues, um, including heart, lung, bowel, and tubes. So, when we look at this, you can see that there are fractures in different stages of healing everywhere, and you can see that the bones are more dense. So what is this condition? So this is either osteogenesis imperfecta or child abuse or congenital hypophosphatasia. So these are some of the differential diagnoses. The most important management is careful handling and treatment of the fractures. What is being used to prevent further fractures is palmidronate therapy, which we start either by third or fourth week of life. And now many of these osteogenesis are amenable to either bone marrow transplant or gene therapy. So the answer for the first one is fractures in different stages of healing, dense bones and bell-shaped chest. Okay. So any takers for this? What is A? So all of you, one thing you should know everything about ROP. Even though, yeah, it is slightly deviating from our field, this is an important part of screening, and also it is an important medico-legal component of prematurity. So we should not miss. So ICROP3 has been recently given, and this is what is A, what is B, and what is ridge evolving from the demarcation, which stage, what is aggressive ROP, and what is stage 5A of So I think many people have answered correctly this question. So everybody is with ROP. The first one is called as posterior zone 2. This has been recently introduced in the ICROP 3. The B is otherwise the macula or the fovea centralis. So the fovea is the centralmost part of the macula. Then when there is a ridge, it is called as a stage 2. What is aggressive ROP? It means that if there is a severe, rapidly progressive form of ROP located in posterior zone 1 or zone 2. So these are the type of ROPs which will just progress and evolve overnight to blindness, and this needs aggressive screening and treatment. And that is why in India, they find this also present in the larger preterm infants. So that is why this new term has been introduced. And what is 5A? 5A means that the optic disc is visible by ophthalmoscopy. So now the 5 classification is classified into 5A, 5B, and 5C. So there is a document called ICROP3. All of you just read what are the changes. That is more than enough. Okay, so visible by ophthalmoscopy is the answer. Okay, so this is a fairly simple question. We should identify the lactation management plan. Mother with treated tuberculosis, will you breastfeed or not? So all forms of tuberculosis except the multi-drug resistance only will be separation. So most forms of tuberculosis, there is no contraindication to breastfeeding. Do not separate mother and baby. Varicella diagnosed on the day of delivery. Yeah, this is tricky that we cannot give direct breastfeeding. The mother and baby will need to be separated till the lesions are crusted. But if there are no lesions of the breast, we can give express breast milk. Infant with galactosemia, of course, breastfeeding is here contraindicated. Mother with retrovirus. I'd see no takers. Yes. So the answer is a vehement yes. So retrovirus is now a very strong program in India where every mother is detected during, pregnancy, and if she is found to be tested during pregnancy, and if she is found to be positive, started on early anti-retroviral chemotherapy. So the transmission chances are quite less. So breastfeeding is the best route. So AFAS and things like that are right now out. Mother with chemotherapy for Hodgkin's lymphoma. Yeah, chemotherapy is one of the contraindications to breastfeeding. Mother with MRSA in wound swab. Yes, she can breastfeed with adequate contact precautions. So when she's dressing the wound and all that, she should ensure that she's doing proper hand hygiene. If the mother is COVID-19 virus positive or any respiratory infection, she can breastfeed, but she should use what is called as droplet precaution. So along with the infections, you should also write the precautions the mother should use. HBsAg positive mother, she can breastfeed and there are no precautions here. Infant with cleft lip and cleft palate, what is the position you will advise? Yes, they can also breastfeed. You will use a straddle or the upright position. Preterm baby 30 weeks, 1.5 kg. So the 30 weeker, so the Pallada feed starts by 32 weeks and direct breastfeeding by 34 weeks. So a preterm baby born at 30 weeks will be started on tube feeds and early oromotor stimulation. And as soon as the baby is ready, transition to Pallada feeds. Okay, so these are the answers which I have told. So first one is direct breastfeeding, express milk. Galactosemia is contraindicated. Retrovirus is direct breastfeeding, contraindicated in chemotherapy. MRSA swab is direct breastfeeding with contact precautions. COVID-19 is with droplet precautions and contact precautions. HBsAg is direct breastfeeding, straddle or Haberman's feeding, and full tube feeds. Okay, thank you all. Any doubts or clarifications? I will stop sharing.
Thank you very much, Bharati.
Thank you, ma'am.
Great, OSCE. Thank you so much. Thank you.
Thank you for this opportunity, ma'am. Thanks.
Welcome anytime.
Yeah.
Bye.